interest of time, maybe we will just get this going. Good evening and welcome to tonight's virtual town hall. We're very excited to have all of you joining us today for this very important discussion on an issue that has not only been at the forefront of some of the concerns that we have seen propping up during this unprecedented time, and with this pandemic taking its toll. It's definitely an area that Friends of Medicare has been advocating for quite a significant amount of time. But I want to start out just stepping back a little bit and introducing myself. My name is Sandra Azokar, and I'm the Executive Director of Friends of Medicare. And we're an advocacy organization that has for the last 40 years promoted the protection and expansion of our public health care in Alberta and with our allies across the country. Today we will be discussing, like I said before, seniors care. We're going to be talking about how we got here, what is happening right now, and where we hope to be at some point in the future and coming out of this pandemic. We're very excited to be hosting our first webinar. We have participated in quite a few now since this pandemic hit all of us. So be kind, because we might have some technical problems, but like I said, this is a great opportunity to get together and have an honest discussion. The panelists that we have this evening, who will be sharing their vast experience and research and knowledge regarding seniors in Alberta and Canada, are definitely at the forefront of shedding light on this important issue. I'm not going to talk very much, but I just kind of wanted to talk about why it is that it's so important that we as an organization, along with all the allies that we work with in the community, talk about this issue. Because when a system is under stress, it is when we see the cracks. And definitely seniors care is one of those areas that the cracks have been open wide. COVID's toll on Alberta's continuing care system has exposed many of these cracks that have been created as a result of decades of privatization and the inequity that perpetual cost cutting has wrought. What we're seeing now was decades in the making. It's just that this pandemic has made it even more real for the majority of people. Seniors in continuing care facilities now account for over half of all COVID deaths in Alberta and in Canada. In Alberta, we have had currently, as of May the 7th, 114 deaths, and as of yesterday, 82 of those were in continuing care facilities. The number of those that have tested positive in continuing care facilities is 632, and it continues to rise every day. I have no idea why Dr. Hinshaw now has stopped reporting exactly how many cases of those deaths actually are happening within our facility. We also don't have clear data as to how many of the workers that work in these facilities have actually been impacted. For decades, we, Friends of Medicare and Seniors Advocates, have been sounding the alarm over the issues in our seniors care system. We have repeatedly called on governments to get profits out of seniors care and to enact patient-staff ratios to address unsustainable work, which leads to burnout for the staff and which degrade the quality of care and attention that seniors receive. We have seen a race to the bottom when it comes to providing quality care for seniors and an ever-increasing offloading of costs and care to seniors and their families. This is why we need to have this conversation. We are going to start out today's town hall meeting with somebody who is probably well known to the vast majority, I would say, of the people that are participating today. I'm talking about Carol Wodak. Carol Wodak is a longtime researcher and advocate in elder care in Alberta. She came to this activity for intensely personal reasons. Her mother experienced almost a full range of continuum care options after suffering a series of strokes from 1995 to 2006. And Carol believes very strongly that the system failed her mother In addition to individual work, Carol is a founding member of Citizens Watch, an active member and vice chair of the Seniors Action and Liaison Team, SALT, and she sits on the board of Public Interest Alberta and is a member of several community advocacy groups. Before I let Carol begin, I just wanted to let you know that if you are as forgetful as I am, when you're listening to our panelists, you're more than welcome to ask questions and answers. At the bottom of your page, you will see a little icon that says Q&A. Fill out those questions. We will be more than happy to go through them towards the end after the panelists have all made their presentations. And the ones that are not answered, or if you feel that you need more information, you're more than welcome to leave your name and we will contact you back, and we will definitely send the questions to the appropriate panelists. So without any further ado, I now leave you with Carol Wodak.
Thanks, Sandra, and hello all. This is really a very personal thing for me. My mother spent the last 10 years of her life in the elder care system. The experience was a disaster. I joined a small group called Citizen Watch. We documented our concerns and our lobbying about elder care. Our website still exists as an archive at continuingcarewatch.com. When you go there, check out the file map as well as the other sections. Forgive us if we say we told you so to anyone who is surprised at the disorder and inadequacy revealed in the light of COVID-19 in the care settings. Today, everyone who pays any attention to the news knows that long-term care is a catastrophe.
Sorry, Carol, can you speak up a little bit?
Sorry, okay, yeah.
Sorry about that.
Okay, we need to know what went wrong and why before we can make good and lasting change. So the path to here was convoluted. The second half of the 20th century was amazing in the care which our recovery from 2 world wars and the Great Depression was planned. Prior to this, older or sick and disabled Canadians were left to rely for care and for the necessities of life on their own resources, on family, private markets, or charities. The policy behind so many of our social programs was adopted from Leonard Marsh's 1943 report on the Social Security for Canada. We can thank Dr. Marsh and the governments of the next 40 years for old age pensions, occupational health and safety, workers' compensation, child care benefits, public housing, social assistance, family supports, publicly funded hospitals, and seniors programs, public health care insurance, and federal and provincial cost sharing for housing, health care, and for social programs. I think it's important to know that we do have this socialist history, which did us all in good stead. Between 1959 and the mid-80s, Alberta evolved elder care in a somewhat irregular path. We created a series of federal, provincial, cost-shared, publicly funded medical care insurance plans, ending with the Canada Health Act in 1984. We built seniors' lodges and created home care for seniors. We built auxiliary hospitals to provide extended rehabilitation care and services to supplement the nursing homes. We banned private nursing home operators, but later we gave them capital grants and long-term contracts. We enacted the Nursing Homes Act to regulate care and services, but then we provided ministerial directives to waive the nurse staffing requirements. By the 1980s, the fashion for public services, and particularly for elder care, was changing. In 1988, a new vision for long-term care, the Marash Report, shifted responsibility and costs from governments to individuals and families, and recommended care in the community to replace nursing homes and auxiliary hospitals. They said people would be given choices. Turned out the choices depended on their ability to pay. A moratorium was placed on new nursing homes and auxiliary hospitals. They were renamed continuing care centers and basically merged with little regard for different legislation which governed them. Access to care was determined by a central committee rather than by the regional health authorities. Services were categorized as core or complementary, and many of the latter were outsourced or simply canceled. Others had a cost recovery fee attached. Population and waitlist growth and poor economic conditions put pressures on the government, which was already looking at privatizing health services and insurance. Alberta adopted a social policy with the central message that primary responsibility for care belonged with the family. Section 6 of the Canada Health Act did provide for federal provincial cost sharing and reporting for extended health services, which included long-term care. But Section 6 was removed in 1995 in exchange for a new formula for federal financial support based on the ability of each province to raise their own taxes. We know that didn't work in Alberta, where governments firmly believe that taxes should be lowered and public services turned into private business, but publicly subsidized private businesses. Over the next decade, staffing and services in the care facility was de-skilled and reduced. Care schedules were developed according to time and motion plans, and the only recourse for any care concern was to the provider. Specialist staff like physiotherapists, occupational therapists, and recreational therapists, as well as laundry workers, cleaners, and meal servers, were replaced by multi-purpose healthcare aides, often untrained or minimally trained and working casual or part-time. Casual and part-time staff need to work at several jobs, usually at other facilities to earn a living wage, and we know where that got us. There was a huge increase in the mostly private facilities we now know as designated supportive living. They were built and operated often with public grants to offset capital costs and with long-term secret operating contracts. This allowed the diversion of folks from nursing homes, and in 3 cases, the homes were simply relabeled supportive living. Initially, the accommodation fees for these settings were unregulated. Eventually, they were capped at the same rate charged for continuing care centers. The deal was the DSL facility provided basic accommodation, and home care provided or funded basic scheduled care services. Costs of furniture, furnishings, medical goods, and pharmaceuticals were the responsibility of the resident instead of being provided by the care facility. By and large, the DSL-3, DSL-4, and DSL-4D serve the same population as the continuing care centers, but a significant portion of the cost has been transferred to seniors and their families. Healthcare standards, care standards, and accommodation standards were created after the 2005 MLA review prompted by Citizen Watch and others. But they were created by industry groups, funded by the government for the purpose, and reviewed by the Ministry of Health, with not a consumer or public review in sight. The care standards mostly say that the facility operator decides what care is needed, and inspections by the Ministry of Health were announced ahead of time and mostly concerned with a review of the operator's policy books. Incident reports were required by the ministry, but only from the facility staff, and there was no public reporting or follow-up. There was really no improvement in the care services then, or following 2 audits by the Auditor General, which recommended many changes. In 2008, the regional health authorities were disbanded and replaced by Alberta Health Services to achieve efficiencies and consistency across the province. That is an ongoing effort. It turns out that every region in the province is not identical. We still have inconsistent and incomplete public reporting, and AHS is still struggling to deal with legacy open-ended contracts with providers. A new provincial continuing care strategy was devised in 2008, again with little if any regard for public consultation. It simply put some gloss on the earlier Maroshan-Broder report. The current government is hell-bent on austerity by lowering taxes, by destroying public services with funding cuts and deficiencies, and creating a business economy from elder care. We already have an elder care with poor access, care in silos with multiple relocations, wait times as resident needs change, fragmented care, inadequate staffing with exploited workers, few and ineffective regulations, no consumer protections, and increasing individual costs, and a system with no capacity to deal with additional stress. What we had at the start of 2020 was a system which had zero capacity to absorb stress. It had been set up to fail. Okay.
Thank you, Carol. That was kind of depressing in terms of where we're at right now. This is, I think, Carol very well summarized what we're seeing now, how we're now seeing the consequences of this history in black and white. So thank you so much for shedding that historical perspective on this conversation. I'm just going to ask the rest of the speakers to speak really loud because we keep on hearing from people that we can't hear very well. Our next panelist is Andrew Longhurst. He is a research associate with the BC Office of the Canadian Centre for Policy Alternatives, a policy researcher with the Health Sciences Association of BC, and served as senior advisor to the BC Ministry of Health's Primary and Community Care Research Initiative. He has authored numerous publications on seniors care, surgical wait times, primary care, and privatization, and a just released study on assisted living privatization and financing of seniors care. Assisted living in British Columbia, trends in access, affordability, and ownership. That's the name of the study that he just released. He holds an MA from Simon Fraser University, where he's currently a PhD student researching healthcare reform in Canada and internationally. So we're very lucky to have Andy joining us this evening. Andy?
Great. Well, thanks so much to Sandra and Alyssa and everyone at Friends of Medicare for the invitation. I'll try to speak as loudly as I can, and if you have any trouble hearing me, just let me know in the chat function, or I'm sure Sandra will tell me if I'm not loud enough. So it's a pleasure to be with you, and really looking forward to the discussion this evening. So I have a short presentation that I want to share with you, and I'm just going to pull that up now. And hopefully everyone's able to see that. So hopefully I'll be talking about the BC context, and hello from Vancouver. So hopefully it will be relevant, and I think it will be, to a lot of the same trends and issues that we're seeing in Alberta. So I want to walk through a few different points that we draw on from the international evidence and a lot of the research evidence from here in Canada, and some of it specifically from British Columbia. So first of all, one of the arguments that we often hear is that we need the for-profit sector to increase access and to help government deliver on long-term care and seniors care more generally. And I want to challenge that argument, and coming at that from here in BC. Over nearly 2 decades, this is research that I published with the Canadian Centre for Policy Alternatives in 2016, we saw an increase in the for-profit sector in terms of publicly funded beds that are contracted to for-profit companies. We saw an increase between 2001 and 2016, at the expense of health authority and nonprofit-owned facilities. And that's been, I can safely say, a trend that has continued in more recent years. And at the moment, I think we have a real opportunity to think about reversing that and looking at the importance of public and nonprofit delivered care in our seniors care system. So while this direction around privatization and focusing on delivering long-term care through private for-profit companies, despite this policy direction, we didn't actually increase access to long-term care and assisted living in the province. Quite the opposite. So from this chart, you can see that across, these are the health regions in British Columbia, across all of them, and then across British Columbia as a whole, we saw a decline. And when we look at both assisted living and long-term care together, long-term care and assisted living together, we saw a decline of 20%. And one of the arguments, I think not unlike in other provinces, is the movement towards supportive living and assisted living models was intended to increase access and provide other models of care. But in BC, as we've seen, despite the movement towards assisted living, it hasn't been the silver bullet, and it hasn't in fact helped British Columbia increase access to publicly funded services. And a lot of this, as I'll talk about later on, has to do with the fact that the capital funding has not been made available to nonprofit and public organizations necessary to increase the supply of long-term care beds and also assisted living residences in the province. So the second issue that we know from a large body of international and Canadian evidence is that for-profit owned homes provide generally inferior care to nonprofit and publicly delivered care. And so this is looking at large data sets, not just single sites or a few facilities, but looking at large administrative data in provinces or in some cases entire countries. So again, what we see is staffing levels and staffing mix are what we would say are key predictors of care quality. So again, is there a certain level of staffing that's being provided? And in addition to that, so again, how many care aides, healthcare assistants, nursing aides, personal support workers, they go by many different names in different provinces, but are there enough care aides to support and meet the daily needs of residents? And then are there LPNs, RNs, physiotherapists, social workers, recreation therapists? Is there a good mix that meets the needs of residents and really provides kind of those structural conditions that ensure that quality of care can be met, and also prevents people unnecessarily from being transferred to hospital or having falls or not being supported in a variety of ways. With staffing levels and staffing mix and low quality pay, we see issues around high staff turnover, and this tends to be more of an issue, I think, as we've certainly seen in recent days and weeks in for-profit owned care homes. In British Columbia, specifically in 2018, the Seniors Advocate in BC released a study commissioned by academic researchers that found that long-term care residents in nonprofit care homes versus health authority owned care homes were 32% more likely to be sent to the emergency department, 34% more likely to be hospitalized, with a 32% longer hospital stay, and 54% more likely to die in hospital. So ultimately, this study raised a lot of concerns about the fact that long-term care is supposed to be a place to age in place and not require transfer to hospital. But a lot of those contracted operators, I think we can assume from that didn't necessarily have the staffing required to support residents, and could not safely care for them without requiring transfer to hospital. So one of the other issues that we've seen, and this is very much an issue in British Columbia as it is in Alberta and Ontario, where we've seen a large growth of corporate investor-owned chains. And from the international evidence, we've seen growing concerns about a lot of the business practices that are employed. So without going into too much detail, I think the bottom line here is that as we see investor-owned chains enter into seniors' care, and we have a long history of looking at the effects and where this takes us when we look at the US and England, for example, we know that a lot of the interest from investors is in the real estate of long-term care and seniors' care more generally. And so these chains are often bought and sold frequently and flipped. And so the interest here is in the real estate and being able to leverage that real estate to acquire more real estate assets, and in some cases taking on so much debt that that these chains require a government bailout because they can't service their own debts. So ultimately, this can result in crisis for these chains, bankruptcy, and failure. And we saw this in 2011 when the United Kingdom's largest care chain, Southern Cross, collapsed as a result of these high-risk financial practices. And it left months of uncertainty for 31,000 residents and their families, as well as 44,000 employees, until other buyers could be lined up to basically take on the assets and the daily operations of the Southern Cross chain. So I have a number of different headlines from a variety of different media outlets. As I'm sure many of you will know, in 2017, the federal government, with the support of the BC provincial government of the day, green-lighted a large investment company's acquisition of the Retirement Concepts care chain, which is BC-based, but also has facilities in Alberta and Quebec. And a lot of advocates, unions, health coalitions, researchers raised concerns at the time about what this meant and a lot of the business practices that might be employed. And what we saw beginning last year was that health authorities across BC had to step in and take over the daily operations, or what's called administration, of these of 4 facilities in BC. Part of the Retirement Concepts Onbong chain. And very recently we saw just in the last week or so, one of these Retirement Concepts long-term care homes taken over by Alberta Health Services, and then subsequently the management has been taken over by another Alberta-based chain. So it's raising, again, we see a pattern emerging that the instabilities created by these business models and the drive for profit is really undermining quality care and stability in the workforce. And so that's been at play in all of these issues where health authorities have stepped in because of staffing shortages, high turnover, and severe concerns around resident safety. The third point that we know from the evidence here in BC was a very interesting report that came out in February of this year from BC's senior advocate again, finding, and she found in that report, after looking at the financial documents and contracts for 174 contracted long-term care homes in BC, that nonprofit long-term care homes spent 59% of revenues on direct care versus 49% in the for-profit sector. So nonprofits, contracted nonprofit care homes were spending more on direct care than their for-profit counterparts. And when we break that down to how much is spent on care aid staff, keeping in mind that care aids are essential and provide 70 to 80% or sometimes more of the daily care for residents. What we learned is that the for-profit sector spends an average of 17% less per worked hour and wages paid to carried staff in the for-profit sector can be as much as 28% below the unionized provincial standard. We also learned that nonprofits spend 9% of revenue on building expenses versus 20% in the for-profit sector. So for-profits are often putting a lot into their capital assets or their real estate at the expense, we might say, of putting that into direct care. And for-profits and staffing. We also learned that for-profits generated considerably more profit, or what in the nonprofit sector we'd call surplus revenue. And of course, in the nonprofit sector, that surplus revenue would go back into the organization, into direct care, into frontline services, and not be going to investors. And then lastly, while receiving on average the same level of public funding, so again, nonprofits and for-profits that are contracted by government, nonprofits spent $10,000 or 24% more per year per resident. And for-profits failed to deliver 207,000 funded direct care hours. So they, in fact, failed to deliver on what government had contracted them to provide, while nonprofits provided 80,000 more direct care hours than they were funded to provide. So while I think this is certainly a BC-focused analysis, I think it gives us a glimpse into where the money is spent, and I think a lot of concerns that we're seeing playing out across the provinces around where the money goes and whether the public, whether we're getting good value when we contract with for-profit companies, many of them very large, and whether that money is actually going into frontline care. The fourth point that I want to close with is, and I'm sure many people have heard the very positive movements that we've seen in BC, where in mere weeks, BC's really trying to rectify workforce instabilities that were brought about over years of labor policy deregulation and business practices intended to drive profits. So we saw BC's provincial health officer move rapidly with the BC government, the Ministry of Health, on issuing a single site order so that no frontline worker in long-term care, assisted living, and mental health facilities, but again, the big issue here in seniors care, to make sure that they're not working at more than one site. And what we've seen emerge over the last 2 decades has been the fact that a lot of care aides and other staff work multiple sites in order to patch together casual and part-time work, an issue that Carol raised in her presentation. So that created a lot of vulnerabilities and created risks around the spread of COVID-19 because workers out of economic necessity were often patching together work at multiple sites. And related to that, subcontracting had become very prevalent and had been actually allowed under legislation beginning in the early 2000s in BC. And a lot of the legacy of that is very much with us today in the province, and that those issues are in fact what the BC government and the provincial health officer have been trying to address in a very short amount of time. And I think it's fair to say that we can't go back to the status quo after COVID-19. These instabilities and vulnerabilities are too great, and it's important that we learn from this experience. The second point is that ownership matters, and it's time to end profit making in seniors care. And we need to maintain existing public and nonprofit seniors care in our provinces. And I think it is abundantly clear that we should not, and I say we, but for Albertans and for the Alberta government, there should not be a privatization of Alberta Health Services owned long-term care homes. And I'm referring here to the plans that were put forward earlier this year to privatize Capital Care and Care West. These are wholly owned by Alberta Health Services. And then we need to be making bold infrastructure investments to end our reliance on for-profit care homes and large corporate chains. And I think this is a call to action for all governments to really, if we're going to take these lessons seriously, we need to be dramatically expanding the nonprofit and public sector in terms of building and operating seniors care. And I think no better time to do that than now. And a point that I'm sure Pat will make, but the conditions of work are the conditions of care, and that structural factors like staffing are necessary to deliver better quality care. And so this means when we have more staffing, we reduce falls, we reduce hospital transfers, and we're actually more cost effective in terms of our system not ending up with the consequences often in acute care because we're not properly staffing and supporting residents in long-term care and other seniors care homes. And then I think all of this means that we need to challenge the austerity agenda, and certainly in Alberta, it's very distressing to see how that is playing out. And I would say it's very clear that Alberta has a revenue problem, not a spending problem. And so I think tax fairness and looking at the economy and its reliance on particular industries like oil and gas, and not looking more broadly at diversifying an economy and the role of public sector and nonprofit sector as part of a diverse economy, that needs to be front and center. But again, tax fairness and looking at how we fund and pay for these critical, essential services, I think needs to be a really brought to light. And I think it has been, and I think there's more appetite than ever to have these discussions and to be ambitious and bold and unapologetic about our need to challenge austerity in all its forms. So I will end it there just by saying I'd recommend checking out these two recent pieces. One of them is a great report out from Pat Armstrong and colleagues. It's available at the Center for Policy Alternatives website. And then a recent piece on Policy Note, also from the CCPA. It's BC focused, but raises a lot of issues that are relevant to all provinces. And I'll leave you with references and resources, and I think share this presentation with Alyssa and Sandra to make available if you're interested in reading more. So thank you.
Thank you so much, Andy. That was a great presentation. And I would like just to point out the fact that we work very closely with our cohorts in BC as well as the rest of the country. And regardless of what they call their continuing care system or how they describe the way that they provide care to seniors, it is always that business model that is the overriding similarity, where profit takes priority over people. And so thank you so much for bringing us that BC perspective, which is, by the way, one of the provinces that our current government likes to compare us to. So thanks. I know that Andy mentioned it, but we are recording this event, and we will be sharing both Carol's presentation and all the other panelists' presentations with everyone who wants to get a copy of it. So thank you so much. Our next panelist is, and we're very fortunate and very happy to actually have her with us, is Pat Armstrong. She's a Canadian sociologist and distinguished research professor at York University. She's a fellow of the Royal Society of Canada and has served as a chair for the Canadian Institutes of Health Research in Health Services and Nursing Research and the Department of Sociology at York University. She's also a board member of the Canadian Health Coalition and the Canadian Centre for Policy Alternatives. Funded by the Social Sciences and Humanities Research Council of Canada. She is principal investigator on reimagining long-term residential care and international study of promising practices. and on the CIHR funded Healthy Aging in Residential Places. So Pat.
Thank you. Thank you for the invitation, and to the other speakers and to everyone who's online or on the internet. That's an old CV. I'm going to have to update it. Some of those things are no longer true, like I'm no longer on the board of the CCPA. Well, I think actually Carol and Andy have covered it all, including what I think has been an affirmative action program for for-profits. Not only for-profit ownership, but also for for-profit approaches in nonprofit facilities. That the encouragement that has been part of the new public management to go in the direction, and for all of the reasons Andy set out, the assumptions about the for-profits being more efficient and effective, and that we should follow their practices even in those small parts of the not-for-profit areas that remain. So I think that what I will do is, instead of doing what I was going to do, is pick up on where Andy left us in saying we can't go back, we need to go forward, and I certainly think that we're going to have a struggle to move forward. So he has offered us some important directions on that, as did Carol. And the first one is to try and get at the for-profits. I was just given some data yesterday for Ontario indicating that the deaths per bed in the for-profits in Ontario were almost 4 times as high as they were in the municipal homes. And once we get those kind of data, it'll help us a bit, I think, in going in the direction. But the question is how. And I know that there are a lot of debates going on, but what is it we're going to ask for? Are we going to say, get rid of all the for-profits instantly? And if so, how are we going to do that? I was just watching a CBC before we came on the air, talking about this new big billion-dollar fund to top up wages of essential workers who have never been seen as essential before in terms of valuing their work. And I think that one of the things that we have to put into this discussion is gender. We have to talk about the fact that a lot of this work gets undervalued in part because it's thought of as unskilled work that any woman can do. And then while we say they're heroes and they're doing it nicely, it's like your mother's a hero, but we don't really think she knows much. I think that that's something we have to push on. But the question that was being raised in the CBC program is a question I've been asking for a long time, and I was delighted to see it on CBC. Thank goodness we still have some public broadcasting left, because they said, why are we paying for-profit organizations to increase the wages? Why don't we just tell them they have to increase the wages and reduce their profits? And it seems to me that one of the ways we can undermine the for-profits is by denying them the ways to make profit, by demanding those conditions of work and the wages plus the broader conditions of work that we think is necessary in long-term residential care. It would make it way less attractive as a place to invest if we started to make those demands. And I think that that's one of the things that we can really think about, is what would make it very unattractive for them to operate in those areas, because we set conditions that are quite different. And I think that in doing that, we have to think through, how do you build and protect a labor force in this area? It's interesting to me, when I went back to look at the SARS report during this time, or at least the reports on SARS, they suggested that there be a national labor force strategy of professionals focused primarily on hospitals. We need a national labor force strategy that thinks about the entire range of people who work and paid and unpaid in long-term residential care. And that includes the excuse me, the cleaners, the laundry workers, and the dietary workers. I was very interested that I was looking at these new federal guidelines that came out for long-term residential care. And they say there isn't anything special that needs to be done in terms of the cutlery and the dishes and the food, or in terms of the laundry. Whereas, well, we wrote a book on this in terms of how important laundry is in terms of long-term care. It can be a source of infection, etc. So when we're talking about a labor force, we have to talk about a labor force that is involved in the entire range of activities that are central to provide care. And as Sandra said at the beginning, that includes families and it includes volunteers. So we have to think of an overall strategy that makes it possible to support that work, and building and protecting a labor force that has decent conditions. As Andy said, central to the work I've been doing forever, and especially to this project, is our argument that the conditions of work are the conditions of care, and we have to go there. And central to that is recognizing the skills. Central to that is recognizing what constitutes healthcare work or care work within these places. And that includes the entire range of people, which is related back to something that Andy was saying about the for-profits. There's been so much blurring of the for-profits and not-for-profits lines. Some of the not-for-profits are managed by for-profit companies now. Some of the, and in Quebec, it's become almost impossible to tell what parts are for-profit and what parts are not. Contracting out the services, outsourcing them, is also, of course, a blurring of the lines of profit and not. So we have to start squeezing out the business-like approaches to running long-term residential care, and we have to squeeze out the profits from all of these sectors, make everybody an employee in that home. And of course, that includes agency workers. I think also that when we're talking about what is to be done, we have to talk about the physical structures. We have to talk about the resources that go beyond protective equipment. There's a lot of focus on that now, but we know the highest rates of absences due to illness and injury are in nursing homes or long-term care homes, or whichever jurisdiction you live in has a different name. But we have to think about what kinds of resources are necessary to make this work that doesn't make you sick, not just during a pandemic, but regularly makes you sick. And that includes where we locate those homes. I was thinking when Andy was talking about the bankruptcy of some of these homes, one of the reasons that they're interested in buying these homes is for the land, and the land is often separately owned. And so then we want to move the care home out into the country, or someplace that makes it really difficult for the workers to get there, really difficult for the families together, and leaves you only watching the grass grow, which is, many residents have told us, is very boring indeed. So I think we have to start thinking very broadly about what it is we want, and it has to go beyond the labor force and beyond ownership, but of course include those things, and of course minimum staffing levels. So the other issue I want to raise is who's to do it? Who should be redesigning these new long-term care approaches? And I think, and this goes back to what Carol was talking about in terms of decision-making in for-profits, but also just in terms of the residents being involved, in terms of the workers being involved, in terms of the families being involved, and of course I want researchers to be involved. But I think we want to really argue that there is a lot of expertise out there, and that expertise comes from, as Carol started out by saying, from people who've had direct contact in these homes. It's amazing to me the number of people who are totally surprised that there are actually places with 4 beds in them. It reminds me of interviewing a Norwegian human resource director who had come from their equivalent of the CBC. And I asked her if anything surprised her when she got to the home. And she said, "Oh, I couldn't believe how hard these people work." Well, anyone who has actually been in a long-term care facility for any length of time has a pretty good appreciation of that, I think. So I want to end by saying, because I want us to have a lot of time to take questions, is that long-term care can be a good place to be. And we started our 10-year project by looking for promising practices. How can we make nursing homes, to use that phrase as a shorthand, how can we make them attractive options? How can we make them places people want to be in, rather than have this seen, as many of my friends say, "I am never going in one of those places." And it makes me think of an interview I did with Residents Council in a home here in Toronto in a project we just finished for the City of Toronto. And I asked them if there was anything better about being here than being at home. And they unanimously said, yes, yes, here we have company. If I was home, I'd be alone. Here we have activities. I know people say all we do is sit in front of the television, but if I was home, that's the only thing I'd ever get to do is the television. And they said they felt safe. But the safe was not just that, I'm not going to get COVID-19, but safe in the sense that an example one woman gave, for instance, is there's always someone to make sure I take my insulin. Safe in the sense that I always get someone to make sure I have the lunch. And I would add one last thing to that. I've had many women say, "Thank goodness I don't have to cook and clean anymore." And on that, I'd like to hear from other people about what we can do together to make this work in the future.
Thank you so much, Pat. That's a great way to go into our questions. Pat has, like I said, she's a wealth of information. So you guys, if you have any questions, we have quite a few right now, so we'll try and get through as many as possible. If we don't get to your questions, please feel free to send them to us. Alyssa Pretty, our communications director, is actually on the background working hard to make sure that this webinar actually goes without any problems, and she has posted in the chat function our email and all our contact information, so you can follow up if you need your question answered, sorry. So we're going to start first of all with a question from Tara. She asks, what are the percentages of poor quality care indicators like incidences of pressure sores and catheter acquired UTIs? Is this much of a factor in private owned long-term cares? I think she didn't mention who that question was for, so if any one of you wants to answer it.
I thought Andy was going to.
I can, so yeah, if I understand correctly, and I hope Carol and Pat will please jump in, but so what we do see is generally pressure ulcers, these indicators of quality do tend to be, we see greater issues, things like pressure ulcers, falls, transfer to hospital in for-profit owned long-term care homes. And that has been demonstrated in the Canadian context, in the US, and other jurisdictions. So I think that hopefully that answers the question, and I hope I heard it correctly.
Yes, it does. Actually, you did hear it correctly. And for that kind of information, we always refer to the report that was actually done by the Parkland Institute that refers to some of those numbers here in Alberta. If you're interested in following it up, it's from bad to worse, seniors care in Alberta. And then the follow-up report that was done in 2016. So we can also post links to those studies, and you will be able to see the difference when it comes to the quality of care that we often see in private versus public. I have a question here for two questions actually that are kind of the same for Carol. One that says, what year, decade were the changes from public to private in our seniors care? And the other question is, what time period did we ban private nursing homes? With a comment of time to do it again.
We banned private nursing homes back in the 70s. Social credit government, bless its heart. They discovered that they weren't getting very good value from those places. And the first question was, when did we start privatizing?
Yeah, what time period did we ban private nursing?
In the 70s.
Yes.
Yes, and the other question was?
And the other question was, what year or decade were the changes from public to private?
Seriously started in 2000. So for about the last 20 years, there's been an enormous shift in the ownership from public to private. And it was Andrew who mentioned that the not-for-profits are in a very difficult position. No, it was Pat, wasn't it? Not-for-profits are in a really difficult position because they belong to the same industry group as the for-profit providers, and they do that for self-protection, I think. And they're the ones that are used to put forward claims for more money or anything else.
Yeah.
When in fact, the claims don't necessarily come from them. But in many cases, they act exactly like the for-profits because, of course, they're in competition with them. It's really a shame to see, especially the religious-based charities that turned into not-for-profit owners of long-term care, behaving exactly like all of the for-profit providers. Otherwise, they'd go out of business. We need to protect them.
Thank you. And again, thank you, Carol, for that answer. Again, if you're interested in more of those numbers and how we got here, that those studies by the Parkland Institute that I like to refer to are also have all those numbers, and they're not up to 2020 numbers, but certainly will give you an idea of how we went from public to private in this province. Okay, thank you. The next question that we have is from Doreen, and she asks, has anyone considered the development of a long-term care inspector program similar to public health inspectors? These educated professionals would be responsible for assessing all long-term care centers for profit and private at any time and would not announce to the LT long-term care center their arrival. In my opinion, accreditation, which occurs at the present time, does not reveal the true picture because staff know when the accreditation will arrive.
I'd like to respond to that if I could.
Go ahead, Carol.
On? Okay. I for years have been saying that what we need is an independent agency to monitor, collect data, to inspect, to deal with problems. Most countries have these. Most of the civilized countries have these. New Zealand apparently has a very good example of that. Britain has one that, despite the recent government changes to it, is still functioning. It's called the Social Care Commission. And it's entirely independent of government. It's not affected by the owners of private facilities. And so it could go and do these things on behalf of residents or their families. And I really think that that kind of consumer protection is essential to any kind of responsible program in the future. That by the way, is the second of my recommendations for what we do in the future, Pat. The first one is that we get elder care included again in the Canada Health Act, and make sure that there is a funding agreement across the country, and then the national standards with an agency to enforce, to monitor, and all the rest of it. Then I think we could probably start breathing easier.
Can I say something in relation to that?
Yes.
I totally agree that we need a federal legislation that is directly related to long-term care. I am very afraid of opening the Canada Health Act because I am really afraid somebody will wreck it, the whole thing. I think we need a parallel piece of legislation that does that. That's where I was going to end, and I'm really glad we went there in the discussion. I couldn't help in thinking when you were talking about inspections, there were only 9 full inspections done in this province last year, and they're now doing them by telephone.
Yes.
Which is,
Wow.
in my view, well, I think it's obvious why doing an inspection by telephone. First of all, you can't even smell, let alone.
That's all right. That's what they do at the meat processing plants in Alberta.
It's unbelievable. But I think we need federal legislation very much like the Canada Health Act, a set of principles, funding behind it, and that the funding's conditional. I agree.
Good, we have a movement.
Yeah. Great to start movements online. Thank you. The other question that we have is from Rick, and he says, given that there is an increased interest in providing adequate care to seniors due to the tragedies from COVID-19 crisis, how would you suggest that we proceed to maintain the interest in improved seniors care and to work towards improvements in seniors care? What approach do you suggest in ensuring that governments in fact respond during this crisis? That's for everybody.
Okay, I have one idea.
Okay, go ahead.
Okay, I would really like to see in each province a public inquiry into what went wrong and why it went wrong in long-term care section and for seniors, because I don't think the data shows exactly how much we were affected by that. I think there were collateral deaths because of COVID putting stress on the facilities. I think there were people who didn't get proper dehydration, who developed other kinds of infections or other health problems, who weren't dealt with properly, who may have ended up in ER if they were lucky. And so I think I'd like to know all of that. And I think only by exposing what really happened will we maintain the interest in fixing it.
Do you have something to add, Pat?
Did Andy disappear? I think that to go back to what Carol said about how after the Second World War, we came out of that war and ended up with some healthcare, with some public healthcare programs. I think that there was a lot of collective community effort to get there. And now they were also afraid of all the promises they made during the war. But I think that in addition to those kinds of inquiries, we can't put it off. We should be starting right now during the midst of this, starting to build towards the kinds of things like federal legislation, that we should do it in the midst of this, not wait till it's over.
And I'm still here, just having video issues, so sorry for the blank screen. I think just to add to that, certainly from the BC experience, and I think this is the case and can be said for many other provinces, and I may take us in a different direction, but I'll say this anyway. With the attraction, I think, of looking to for-profit companies and contracting with them has been that many governments don't want to put the upfront capital costs in the short periods in which they're in power. There is a lot of political hysteria over putting debt onto the provincial budgets in every province. And so I think as we move from COVID, I think we really need to be talking, and if governments are serious about reform, they need to be willing to commit those dollars. And I think so over the long run, we actually end up paying more by relying on for-profits, because in many cases, we're actually paying for them to acquire a large portfolio of real estate that we have indirectly, as citizens, paid for. And a lot of that is included in the rates that they charge government. So we've actually paid for this infrastructure, but governments avoid putting those capital costs on the books, so to speak, or having it show up on the provincial accounts because they don't want to show any accumulated debt. And so I think politically that's the attraction. I think moving forward, we need to be thinking about the fact that we pay more, and that COVID is a real opportunity to rethink the kind of investments over the long term.
But if I could add to that, it takes us back to what you were saying about austerity. It's partly the way budgets are done. Coming out of this, there's going to have to be some transformation in the way budgets are being done so that it doesn't all go into this year's budget or into the next couple of years' budgets. The advantage to handing it over to for-profits, as we're saying, is that you pay over the long term, but it only a small part of that shows up this year, right?
Yeah, and I think, and I'll just very quickly, I mean, I think with a lot of infrastructure, though, we do see it financed over a longer time horizon, and so I have been puzzled by the reluctance to finance new seniors care facilities and infrastructure, because it doesn't seem like it's not just a one-time investment and showing up in one election year, one political cycle. So, I mean, I think it's probably more than that. It's also just these are political decisions that are made and not necessarily rooted in any evidence base, but purely, again, political decisions about how do we choose for-profits over public sector and nonprofits.
Perfect. That kind of takes us into a question that has been asked a couple of times now. Given that improved seniors care will be more costly or like increased salaries or for caregivers or better working conditions, more staff, etc., who do you feel should pay for this increased cost? And that was initially sent to Andrew, but I'm sure that everybody has something to say about that.
I might send it back to Pat and Carol since they just spoke.
No, go for it.
Sandra, do you mind posing that question very briefly again?
Yeah, given that improved seniors care will be more costly, increased salaries, for example, for caregivers, better working conditions, more staff, etc., who do you feel should pay for this increase in cost? And I think all of you were touching on that subject with our previous question, but if I could just butt in here, in Alberta, the operational funds that go towards staffing, paying for staff in contracted out seniors care facilities, according to Alberta Health Services, is the same amount that workers are paid for in public facilities. Yet private for-profit and not-for-profit operators often pay the workers less. And that has always been an issue that has been highlighted by labor disputes in this province, where Alberta Health Services says, no, we give these operators the same amount of money, both for private and public, yet nobody's questioning the providers when they're paying their workers less. So the money is already there. When it comes to building facilities, we have built almost all our public, all our seniors care facility under the Affordable Supported Living Initiative, which gives these providers 50% of the capital cost to build these facilities, yet we don't own them. And this is what we saw, for example, with aged care, who built quite a little empire and then sold it to a real estate company, and then they were left as the contractors and just leasing and operating and maintaining these buildings after they sold them. But yet we gave them 50% of the money to build this empire. So again, the money is already there. It's how we allocate it, and with the transparency that we allocate this money. Sorry.
So I think I would just say, I think the question is, where does the money go? And I just to build off of Sandra's point, I think, and this is what we've seen in BC, where on average, the Seniors Advocate found that contracted nonprofit and for-profit operators are receiving, on average, the same amount of funding, and yet there's significant differences in how they spend that on frontline care. And the wage discrepancies for care aides, it can be very significant. So I would counter the idea that it's actually in many ways going to cost us more than it actually does, in the sense that we are already paying for a lot of this. And in fact, we're not getting the care that we're paying for. It's going into the 10 to 12% or more that is expected in terms of the profit or return on investment from a lot of these companies. And then we have no accountability around how the public dollars are being spent. And I think, so the issue is not necessarily that it's going to be more expensive, although I think there's a bigger conversation about what would it take to increase significantly staffing. But I think when we pull out that 10 to 12% margin, we create quite a bit of room to increase staffing and to put that right back into care. And then I think the bigger question is the capital investment, so the actual buildings and the infrastructure. I think that's where we would see government would have those costs in a way that they don't have them now, but like we see with a lot of public-private partnerships, over the long term of a project, the public ends up paying more for infrastructure than it would pay for if it financed itself. So, I think I'm not actually convinced that we would necessarily be paying more. I think there is a significant amount that is being diverted to investors that is not going into care.
We should also look at the cost of not doing this. Some of what we're spending right now is directly as a result of what we haven't paid for. And
For sure.
Sandra?
No, is that it, Pat? Sorry.
yes, sorry, I'm done.
Okay. And Carol, did you want to say?
Yeah, a number of points. One is 10.8% in 2018 was the profit return to for-profit operators on their operating costs. We wouldn't be paying that. We would be saving that. Second, any money we pay in wages goes back into the economy.
Yes.
Right. I mean, that's not an expense, that's an investment. Third is we'd be avoiding a lot of downstream costs for not providing good care. And I don't think anybody's calculated that, but I know that when I ask the Minister of Health about the costs of long-term care, whether she would include the out-of-pocket costs, she doesn't. And I think those are really significant, what people are paying out of their pockets to supplement the public spending wouldn't be necessary anymore. And I would include lives in that. We would be saving lives. And I think that has a value. Yeah, that's it.
That's okay, thank you. I have another question from Kate that says, if the provinces see another outbreak of COVID, do the panelists believe that isolation measures such as the ones put in place this time are necessary, knowing that many seniors felt like and still feel like they are in prison, knowing that isolation decreases immunity, knowing that isolation is directly linked to depression, knowing that isolation means less exercise, and knowing that isolation means these valued members of our society are now denied access to their families? family? Can the panelists recognize that the isolation they are placed in has many negative repercussions? And could they see that possibly the repercussions outweigh risk of contracting a virus? And if so, how do we raise this concern to our government? Good question.
Huh?
I thought you were going to go for it.
No.
I think that we need to, in this inquiry that Carol's going to get going, make sure that we look at the extent to which we could have had alternatives. Certainly the congregation of people in particular places could help us not leave everyone else in isolation. And it's also become clear, I think, that it wasn't necessarily the case that you should have been locked in as opposed to being allowed to go out physically, depending on how the place is structured, which is, I think, something that we should think about. But I also think that, you know, we have to start to think about some risk, balance safety and risk, balance risk with thinking about making life worth living. That we can't solely focus on safety. I mean, COVID has been a particular thing. I think that there's an interesting lesson from Kingston, Ontario, actually, which goes back to a previous question. They took their restaurant inspectors when the restaurants closed and put them into the nursing homes. And they haven't had any deaths in Kingston. And that's an important lesson there. They did some congregation, they did tracing, but they didn't do as much isolation as we have seen in other places, and yet they prevented any spread. So I think that there's some lessons we can learn about asking the kinds of questions you were asking. Do we have to go to the isolation of everyone in the way we did? Do we have to keep families out? Do we have to keep volunteers out? Or can we provide them with the kind of training and equipment that they need to continue to come in, for instance?
Perfect. Thank you. Go ahead, Carol.
Yeah, I'd just like to add that I think that was probably overkill, banning all visitors. First place, it wasn't the visitors that were spreading the virus. It was the workers, and that was partly because of the multiple places that these workers were working, and also perhaps what their families were involved with, travel and so on. But what we did was not necessarily keep people in the facility safer. What we did was take away at least a third of the care and comfort they were getting.
Yeah.
And I think that probably caused as much damage as the risk of infection from family members. Now, I really do think that the checking for symptoms and so on, and tracking and all that, and personal protective equipment, and the hygiene of the place itself are probably more important factors.
I agree.
Thank you. Yes, definitely agree. I have another quick question. Actually, none of these questions are quick, but could you comment to all the panelists, could you comment on the effectiveness of legislated staffing ratios and improved quality and hours of care?
Enforcement. Unless there's enforcement, it's not going to be worth much.
Well, minimums can become maximums, and there can be gaming. You can, to go back to something you said at the beginning, Carol, you could call, if it's nursing staffing, which is usually the focus of minimum, it's the nursing staff. So then what you can do is fire the people in the kitchen and call those people who do that work part of your nursing staff. The other way those minimums get gamed is by counting everybody on your books as opposed to who's actually on the floor doing providing care. That could include people whose jobs are administrative, but it could also be people who are off on maternity leave or vacation or sick leave or whatever. So in the U.S., they have started to require daily staffing levels of who is actually in the room, actually providing care, and have used those minimums. I think there's a debate, but I think minimums are better than what we have now, because across Canada, only minimums are an RN. Well, in some jurisdictions have minimums, but they don't come near the 4.1 hours of nursing hours per resident per day that was established in the literature more than a decade ago, before we had the kind of complexity we have now. And I was just talking this week to Charlene Harrington, who is a big expert on this and was part of our research team, that she said the new research is suggesting that given the acuity levels, that should be 4.9 hours of nursing care. And again, it's nursing care of who is there doing nursing work.
So I'm just going to add, I don't know where Andrew is. We can't really hear you, Andrew. But
I'm here. Sorry,
oh.
My video for some reason is choosing not to work.
Oh, that's okay. But before you go on, because I know you have information what BC actually has legislated, but in Alberta, the only place where there's any kind of formal conversation about staffing to patient ratio is, or even how much direct care or unpaid care or whatever they call it nowadays, is under the nursing home operations regulations that talks to a minimum of 1.9 paid hours of combined nursing and personal services per resident per day. So that's 1.9 when Pat is calling for 4.9 nursing care, which is a huge difference. That would be the equivalent of direct hours of care, where there's actually somebody touching the patient, as opposed to paid hours. Because what operators can do is say, well, we are getting paid for 2 staff, but if my staff doesn't show up, I'm still getting paid for 2 staff because that's how many I'm saying that I need. But there is actually no direct care happening, and that's a huge difference here in Alberta of what we see when it comes to shortages of staff and not enough people doing hands-on care for patients. I saw Carol and then Andrew.
Yeah, you touched on it, Sandra. Here, an hour of work is a paid hour of work, which means every hour you spend on holiday or sick time or eating your lunch or anything else is counted as the care hour. That has to change. The other thing is one of the things that occurred in California some years ago, and I think it's reasonably effective, is that facilities were required to post the care staff and the shifts they were working publicly in the public areas of the facility, which allowed people to assess whether or not that was actually happening. And requiring that sort of public exposure is really important, I think.
Not to go on too long, but I would just add, so in BC, there's no legislative minimum staffing levels. There's a provincial guideline of 3.36 hours, which is still a far cry from the 4.1, which was recommended in a landmark US study that's a bit dated now. But I think, back to the ownership piece, I think the challenge with a focus on exclusively on regulation and oversight, while that's important, I think the challenges certainly we've seen in the US, and I think that are coming to light very graphically in BC and across the country, is it becomes very hard when you have a profit motive to enforce that. And so governments can spend a lot of resources and a lot of time trying to regulate and ensure that corners are not being cut when labor is, as we know, the biggest expense. And so a lot of companies are going to find ways to try to reduce those costs. So I think at the end of the day, we will spend a lot of effort. And I think the US kind of gives us a sense of, if we choose to go in this direction, we will end up with pretty large chains, and chains tend to hire very expensive accountants and very expensive lawyers, and governments are often will be very challenged in terms of trying to enforce a lot of minimum standards. So a lot of that is to say, if we focus on taking profit out of the system, we can avoid a lot of those issues.
Perfect. Thank you, Andy. I'm just going to give each of you a few seconds, actually, just to give us some final inspirational words before we actually talk about some of the action areas. We're kind of running short of time, but I'll give it over to you, to whoever wants to start.
We're going to use up all the time this way. Why don't we go in the order we spoke?
All right. Okay. One, I like the idea of parallel legislation, as long as it has all those principles and all the ideals in it, and the committed funding and funding arrangement, not counting on tax points. And yeah, I think we need to start lobbying for that absolutely right now. And I also think we mustn't stop asking questions and asking for an explanation of how the hell did we get in this mess? What damage did it cause? What do we need to do? I think we need to ask those questions and insist on answers. And I think that could be a popular thing.
Thank you, Carol. Andy?
Well, I think we need to move to 100% nonprofit and public ownership of publicly funded care, and I think it should go beyond long-term care. And I think to be effective, we're going to need the federal government to really make a commitment with federal transfers and its federal funding ability to really require provinces to move in that direction. And I think that's a mechanism that we should not neglect, and that I think is really critical as we move forward, the role of the federal government to play a leadership role and really work towards national standards and rebuilding seniors care in the country, and on the basis that it's not for profit, whether that be publicly delivered or with nonprofit organizations. And I think that's going to require work across all provinces in terms of what that plan looks like, but I think it's more essential than ever.
Thank you, Andy. Pat?
I agree with all of that, and I think we shouldn't forget we need to put joy into these places.
Thank you, Pat. That's a great way to end this, and it kind of leads us into some of the reality that we are currently faced with when it comes to the questions that has been asked quite a bit during this question and answer period is, what do we do and how do we get our voices out there? And for us, we have a few ideas. This is a new reality that we're all facing when it comes to not being able to go out to the streets and demand better from governments. But in the meantime, we're coming up with some action ideas. If you're interested in writing your MLA, your health minister, Premier Kenny, to let them all know your concerns, we urge you to do so. If you want to fill the template letter that we have on our website, please visit www.friendsofmedicare.org. Alyssa put all our contact information on there so that if you need help writing a letter, we can help you. If you feel comfortable doing it on your own and you don't know how to get in contact with all these people, we'll let you know as well. The more that they get, the more that they are aware that people are on top of the situation, and hopefully they'll know that there's pressure, that we're not just sitting by waiting for this to happen and for it to be over. We're also working with Public Interest Alberta Seniors Task Force on our ongoing campaign, abseniors.ca. Go on that website, sign the pledge, share the videos that we work very hard to put together that address quite a few of the areas that you have heard about tonight. The other thing too that we want you to keep in mind is that on May 26th, we will be engaging in the launch of an online campaign that will include all social media platforms. We want to continue to push this government to do the right thing. And following that media online campaign, we will be doing a phone blitz and trying to get in touch with as many rural MLAs as some of those rural communities that we have in this province are even more hard hit, but nobody's talking about them. I definitely want to thank all our panelists for sharing their experience and an incredible amount of knowledge. I want to thank all of you for being here with us tonight. This is not the first well, this is the first, but it's definitely not the last social media event that we will be holding. If you didn't get your questions answered, we have a copy of them. Alyssa has done a great job in terms of ensuring that we have them, and we will refer them to the appropriate person or try to answer them ourselves if we can. And my only last message is that this crisis definitely must serve as a timely indicator to our government that we need an immediate reevaluation of how we're providing seniors care in this province. And our reevaluation must include, as many of the panelists have mentioned, is bringing seniors care under the public umbrella, full stop. And that's what we will be fighting for. We cannot go back to normal because normal in Alberta was woefully wrong. And seniors deserve better, and we have a responsibility to make sure that they are getting the care that everybody deserves and needs. So thank you again for sharing this evening with us, and we will definitely continue to fight in this front. Thank you again.
Thank you so much.